Okay, thank you. So I'll be talking about complications in cataract surgery, but rather than keep a very exhaustive theoretical talk, I'll just be taking you over as many videos as my time would permit. Now, the most common complication and one most of us have encountered and we would want to deal with well is a posterior capsular rent. We know that once we have a PCR, we see a bright red reflex, and AC may deepen, the nucleus followability goes away, vitreous surfaces and may clog your phacoprobe. But what is it that we intend to achieve now? Our intention is to clean up the bag in terms of nucleus and cortex and not extend the PCR and have a place to put the IOL. And while doing so, prevent vitreous prolapse, vitreous hydration, and therefore the consequent complications of CME, retinal detachment, and even infection. Do note that with every case of PCR that you have, you increase the risk of endophthalmitis by 4 to 5 times if not handled well. So these patients, of course, do require intracameral antibiotics. I know many of us have moved to intracameral antibiotics for all cases, but at least for complex cases with longer surgical time, they are an absolute must. Now, let's just go over a series of cases. You see here that this is the anterior capsulorhexis margin, which has torn and extended into a PCR. Now, what is being done right and wrong here? What is right is that you should not use coaxial, you should use bimanual. But you see here, it is a vitreous strand which is actually being trapped and pulled. This is wrong. When there is vitreous, a simple IA will not allow you to cut it. You can aspirate the cortex, but you must cut the vitreous. So dragging the vitreous like this would increase your risk of CME and retinal detachment. Now, this is right. You have come in with a vitrectomy cutter, but it should not be through the main incision. Ideally, because to make a snug fit, it should be through the side port. When you have it through the main incision, you are going to depressurize the anterior chamber and more vitreous may surface. However, this is a good vitrectomy being done by expert hands. The bimanual irrigation piece is being used to maintain the anterior chamber. You see, this is a different direction. And you see the cutter pointing upwards will go beyond the PC rupture 1 to 2 mm. And so you're pulling the vitreous back. Another thing that could have been used at this stage is the use of triamcinolone, but in expert eyes, visualization is easy. What is being done here is the aspiration of the cortex using the cutter. Do note that the cutter has a cut IA mode for the vitreous and the aspiration mode also, the irrigate the aspiration mode also for the cortex. Now, you have here a capsule that is deficient, but you have opposite 3 clock hours that is enough to implant a stable IOL. A single piece IOL must not be implanted in this case, and a 3-piece IOL is being implanted. The incision is being increased because a 1.8 incision does not allow the injection of a 3-piece IOL. The tricky bit here is that you have to place it in the sulcus, and there is a vertical rip here right across 180 degrees opposite to the injection site. So you do have a risk of the haptic falling vertically downwards. To avoid this risk, you can either place the IOL over the iris or keep one end of the haptic dangling out from the incision, which is what is being done in this case. Because if one end is dangling out, you will not get a IOL to drop down through the large rip that we have in the posterior capsule. Now, it is important to note that you must have a good visualization, that you are ensuring that the haptics are placed above the rex's rim. If the pupil at this time is not dilated, do not even hesitate from putting hooks. And you must now dial in the haptic into the sulcus. If you put a single piece IOL in the sulcus, the thick haptics will rub across the iris, cause pigment dispersion, risk uveitis and glaucoma, and inflammation in the eye in the long run, leading to complications like CME and endothelial damage and glaucoma. So do note that a three-piece IOL is the IOL of choice in all cases with PCR. This IOL will center well if there is no vitreous, but if there is vitreous, you will not see it center as well. And that is again a sign for you to go back and check on complete vitreous removal. So take home messages from this video. First, if you have a PCR, notice it, don't move out of the AC. You see here that when you are moving out of the AC, you must put in a viscoelastic. A viscodispersive is a good tamponade. If you depressurize the AC, more and more vitreous will come out. And vitreous herniation will increase. Second is triamcinolone unpreserved is a good adjunct because it gets adsorbed on the vitreous and will assist you in complete vitreous removal. The third is that a good effective anterior vitrectomy will require stable ports. Don't go in through the main port. Have good snug side ports. Dissociate the irrigation and the cut. So this is, you can put an AC maintainer separately towards the iris plane, away from the PCR, and a cutter which goes in through the a little posterior from the cut and pulls back the vitreous. Now, something which has become very popular is the use of Parsplana technique for managing rents. You see here, this is a traumatic cataract with an anterior and a posterior capsule rupture. The coaxial IA is being used to aspirate the cortical matter because it's soft, but we are not able to aspirate because it is admixed with vitreous. At this point, again, we don't want to be aspirating vitreous without cutting it. So this is not the right approach. Because there is a large AC and PC rip, the Parsplana approach is being used for doing a vitrectomy. When you go in through the Parsplana, this is, they call it bringing the vitreous back home. You're going in from a posterior location and pulling the vitreous back. So when you don't pull anything up front, you don't cause more vitreous to herniate. And this is a safe way of reducing the expansion of a rip in the PC that is already there. So the capsular tear does not extend and an effective vitrectomy can be done. Do note that from the cut IA mode, you move to the IA cut mode to aspirate the cortex with a simple yaw on your machines. When you are using a vitrectomy cutter, try and maximize the cut rate and work on medium to low flow parameters. This will give you, through this technique, you are getting an effective cortical and vitreous removal, moving from the cut IA to the IA cut mode, depending on whether you're dealing with vitreous or cortex. Do note that an infusion has been placed through the Parsplana to keep this globe stable. And because there is now no longer a compartmentalization, you can also have an AC maintainer for the same. Again, this is a vertical rip and a three-piece IOL would be positioned well here. I'd just like to highlight again that please be cautious while putting a three-piece IOL, either implant it over the iris and then dial it in, or you will have to keep one end dangling out to ensure that though this has vertically dropped, it has still not dropped into the vitreous because you have access to one haptic which you can latch onto. In fact, it's gone so vertical that we actually, since we have access to Parsplana, posteriorly levitate this IOL and put it back into position. Though there is no intact capsular axis, 3 clock hours of consistent capsule, good capsular support, 180 degree apart will give you enough space to put this IOL in a stable manner. Now, moving on to the next case, fortunately, in both these cases, you have had only soft cortex to deal with. What would you do if you have a large heminucleus still remaining? You don't have a posterior capsule, so this may drop back into the vitreous, and that is a complication that an anterior segment surgeon can't handle. So this is a technique popularized by Dr. Amar Agarwal, wherein a three-piece IOL again comes to your rescue, and you put it behind, after levitating the nucleus piece up, you put it behind the nucleus piece so as to give you a life jacket or a lifeboat of an IOL scaffold. Do note that this technique works well for soft cataracts. I would not recommend it for moderate to hard cataracts because you risk endothelial damage to a significant degree. This is just a pictorial representation of how the technique is done. You see that the nucleus has been levitated up into the anterior chamber. The IOL then put behind the nucleus. Again, you can keep one end of the haptic dangling out because you don't know whether you will need to fix this IOL or this IOL will go into the sulcus. Of course, if you have an intact capsular excess, this IOL will in all likelihood go into the sulcus and can then be optically captured. Do note that a viscodispersive, a viscode kind of a viscoelastic is really the lifeline for doing such a maneuver in the anterior chamber. Now, this is a femto cataract being done. This is one of the earlier OCTs. The technology has progressed and the OCTs have become better since then. But what you have here is a capsular excess being fashioned. When you do have an increased risk of PCR, a capsular excess of about 5 mm is ideal because it will give you good enough support to put the IOL in the sulcus and even optically capture it. A very large capsular excess will make optic capture difficult. Now, what is the problem here is that we've done a hydro maneuver and not decompressed the bag. This bag has already been inflated by the byproduct of femto, which is the gaseous byproduct. You see here that the red reflex has become very prominent. That's so because there is no PC. Now you have no posterior capsule, but you have a large heminucleus. So what we're going to try and do here is to resort to the IOL scaffold technique. The only flip side is that a femto has already segmented and softened this heminucleus, which will cause this to not come out in a single piece, which would be easier had it been the conventional method. But we still bring it up in 2 pieces, which have been segmented through the femto. Once it is in the anterior chamber, the IOL scaffold technique is going to be followed, and the 3-piece IOL will be inserted behind the nucleus pieces. Again, viscoelastic a must. Between the piece and the corneal surface. Once the note here, the IOL is still above the iris. Till you've done your complete cleanup and you've really been sure that now you can put the IOL in the sulcus, you will now again dilate the sulcus and you can optically capture this for greater stability since you have a good rhexis. This is the case where the 3-piece IOL has been put where there's been a large capsular extension into a PCR and it decentered. So we again went in and cleared the vitreous, but it did not center again. Such a case where there is inadequate capsular support will require fixation into the sclera. The 3-piece lens lends itself into easily to a glued IOL technique. You see here that the same haptic is captured and externalized to the sclerotomy, which can then be embedded into the sclera through a track created by a needle. In the interest of time, I'll just show you a better video. This is how the externalization works, and then you are simply embedding into the sclera and keeping the flaps back on with glue. Just one last video. Just look at what's happening here. This is a case that had a non-dilating pupil in the other eye or dilating to less than 6 mm. And what we are faced with is a floppy iris. This patient had been taking tamsulosin, and the resident had not taken history of that. And this is what you will be faced with. You have the iris prolapsing out. If you're going in on high parameters, this floppy iris can actually get sucked into your port, and then you basically end up with a massacre of the iris. And this has to be avoided at all costs by taking a good preoperative history. Note that if a pupil does not dilate above 7 mm, you will most likely face a floppy iris. You may need to use atropine preoperatively. No point stopping the tamsulosin because the effect usually remains. I personally feel that a good viscomydriasis and use of phenocaine dilates this pupil well and keeps it well in place for the phaco. Use low flow parameters, dilating devices if you feel you're not able to manage the billowing of the iris, and try and minimize the number of times you enter and exit the eye. And you will be able to manage these cases successfully. Another thing that you saw the iris prolapsing in the incision site, for that a hook should ideally be placed in a manner that the iris is pulled away from the site of entry. I don't think I have enough time, but just to show you with low flow parameters, a pre-segmented nucleus, good control of your AC and your maneuvers, just going in once and not doing repeated maneuvers, using viscomydriasis and phenocaine, you're able to stabilize the iris enough to even go in through a small pupil like this and remove all pieces effectively. Of course, for IA, you need to visualize. And for that, you can use a Y hook to really pull back the iris and make sure that the cortical cleanup is complete. So all in all, with improved techniques and instrumentations and technologies, we are now able to handle complications with greater ease and able to face our challenges, grow as surgeons, and give better outcomes to all our patients. Thank you for your attention.